I didn't go the last time, so I can start today. I've got some left
Great.
cases I can share. Let me share my screen. All right, here we go. Okay, this is a new case that was pretty cool. So this is a young guy who has a history of recurrent infection, and you can see he's also had some surgery at a younger age. He's got kind of a little bit of curvature spine, but he has this kind of consolidation with a bunch of holes in it, some fluid levels in the left lower lobe. Here's the lateral. You can see again those fluid levels. So not your run-of-the-mill community-acquired pneumonia. You'd wonder about something underlying. So he had a series of CTs. This is a more recent one. And what he's got, let me start with the lung parenchyma first, is he's got this very complex cystic space here in his left lower lobe, pretty extensive, and you can see some of them, they don't have the fluid levels at the time of CT, but what's really cool is this monster artery coming off the aorta going in there, and it's got little branches that come in there. So this is a giant sequestration that's draining that's in this left lower lobe that presumably has become infected more than once. And I wonder if it's a hybrid lesion, hard to tell, but it's clearly had problems for a while. But this was the first time we had a contrasted study to see that. So probably one of the largest supplying arteries I've ever seen. And you can see the little bit of scar there, but the rest of the lungs are normal looking. So intralobar sequestration with a giant supplying artery. This is a kind of impressive case. So this guy is in his 40s and presented with a chest wall mass. And you can see this abnormal density here. And if I show the lateral view, you can't see it quite so well. But it also looks like there's an intrathoracic component in there, maybe an effusion or something. So he underwent a CT scan and at the outside, and you can see there's this large, let me get this out of the way here, mass here in the chest wall. Now this part here is centered on the rib, and you can see it's destroying the rib, but it also has a lot of matrix in it. Whereas this component here doesn't seem to have any matrix in it. It's sitting in the prevascular mediastinal fat. There's a little bit of effusion. Now, if we fast forward just about 3 weeks, and at this point, this is when he came to ART and was transferred to us or referred to us. This effusion had gotten much larger, but this is a mass here. I think this was interpreted as an effusion elsewhere, but this is actually a soft tissue, that mass that was there before. So it's grown rather quickly over the course. It's pushing on his heart. He was having a lot of pain. And so this was biopsied, and this is a dedifferentiated chondrosarcoma. And so you can see this portion here looks like your typical chondrosarcoma. They got some cores from this area too, and this showed the dedifferentiated component. So this was the part that was aggressively growing. There was discussion of treatment, whether it's start with neoadjuvant therapy, but after discussion, the consensus was surgery was the best option up front to get this out to relieve his symptoms and the mass effect on the heart, followed by some adjuvant therapy. They resected this thing en bloc, took a piece of the lung, took the chest wall, took the diaphragm, and a piece of the pericardium, but it was all fairly well encapsulated. You can see there's nice tissue planes. So this whole thing came out, and patient was doing fine. So just a really big sarcoma, but I've seen this phenomenon a couple times where you get sort of a dedifferentiation and you have matrix on one portion and the other portion is pure soft tissue. And we've seen these with some liposarcomas, and then these can be more aggressive than the more better behaved components of the sarcomas.
Yeah. Well.
So,
right.
Jack, the other situation in which you see that effect of different clones, different components of the tumor is with metastasis, because sometimes you'll have a tumor in a primary site that metastasizes, and the metastases grow faster than
Right.
the original tumor, and it's probably because they are a more malignant clone.
Right.
Yeah.
Good point. All right, and then this is a fun case. So this is I can't remember how old, but I think middle-aged female patient who carries a diagnosis of tuberous sclerosis complex and has a nice collection of findings. Let's see if I can find them all. So first of all, and this is, I didn't know they get this, but this is an abdominal CT. She does not have any AMLs, but she presented with this giant pelvic mass. And this was biopsied, and these are all um, tuberous sclerosis related tumors. So not a malignancy here. And then here's her brain just to show you. She's got, let's see if I can. See a couple of the abnormalities. That's it. Yeah, these little punctate areas here. I think better on the flare. But yeah, there they are, the little tubers, so-called. And then on her chest, there is a little, I think she was the one that had a little bit of fat in the LV. I think this was the one, maybe not. Yeah, right there. There's a little fat in the myocardium. And then she did not have, is this the one? She did not, I need this one, sorry. She doesn't have LAM, but what she does have is the pneumocyte hyperplasia. It's got these little nodules kind of scattered throughout. So I find a couple of examples. These little guys here.
Hmm.
So this is, we don't see this much. I've never seen it with sporadic LAM. I've seen it with tuberous sclerosis, but this is presumably the pneumocyte hypoplasia. But I've not seen uterine masses in patients with tuberous sclerosis before. Let's see if I remember what I wrote these down. I just wrote uterus. Yeah, so multifocal micronodular pneumocyte hyperplasia. So that can be a finding of TSC.
Yeah, I don't usually see it because I don't look below the liver.
Yeah, I mean we don't either.
I'm
That's how
joking.
she showed up, is with this pelvic mass.
So Jeff,
Yeah.
what was the histology on that pelvic mass?
I'm trying to remember what they called them. I think they called them picomas.
What are they?
Yeah. Picomas could be really big lesion.
What is it? So something epithelioid.
Perivascular epithelioid. Something epithelioid. Omas.
Where do you get them?
Oma.
Can you get them in the chest, or are they smooth muscle tumors? Like what are they?
Yeah, I've seen one in the axilla present as a mass. I've never seen it in the lung.
Well, you can see them in the mediastinum theoretically. I've never even heard of it.
So yeah.
Pecoma. Okay. It's a new one.
Pecoma, P-E-C-O-M-A, yeah. Picomas. I forget, epithelioid something.
Yeah, I'll look it up real quickly.
And they have a very distinctive appearance under the microscope. And it's a family of
They can affect
tumors.
stomach, intestines, lung, female reproductive organs, GU.
Yep.
Perivascular epithelioid cell neoplasms. That's what they're called. Yeah.
Yeah, I think tuberous sclerosis, is often associated with picomas. So yeah.
Exactly. So that's one of the things that they do. So we've seen AMLs, we've seen LAM, and we've talked about the fat in the myocardium, but this is the first time I've seen uterine ones. And then we talk about the pneumocyte hyperplasia, but I've never seen it except this one time. Alrighty, that's all I have. Who'd like to go next?
I can go.
All right.
Where's my screen? This one? Is that it? Yeah. Anyways, I'm just going to show this real quick because Jeff shared a case with us earlier. I'm telling you, man, it looks so similar. with this peribronchiolar ground glass. Jeff, anyways, he shared a case with us earlier and was
Yeah, it was
wondering what it was. I mean, it just looks so, and this is what he developed over time.
it looks just like my case from this morning.
Yeah, that's what I'm saying. That's exactly what I'm saying. Like it's so, you showed it. I'm like, oh my God, it looks exactly. And I just pulled up the case now showing it, this patient with GPA. But
Yep.
anyways, I don't know if that's at all related. This is not a rare diagnosis, but something I just haven't seen associated with this diagnosis before. So here's this patient this is like January 2021. And she has a history of a salivary gland tumor. I can't remember which one. A little bit of thickening here along the intratracheal septum. I don't even know if it was called or not. Probably not, doesn't matter. Here, the patient is a year or so later, and a little bit bigger. And again, I have to look at the reports. I'm not sure if it was called or not. It may have been actually on that one, but I don't think they acted on it. And then here she is a year later, and this thing is quite big. So kind of went from just a little bit of thickening along the septum to a little bit more nodular to a pretty big size mass in a year and a half. And this does turn out to be a myxoma. I think we've done cardiac imaging, see a fair number of myxomas, and, they're obviously tumors. I just don't know. I'm just trying to see if I don't know if I've seen one grow this quickly. And one thought was that maybe there's a lot of clot associated with it, but this is a very T2 weighted imaging. And it's mostly fluid because these are highly cystic tumors. That's the myxomatous elements. And on the path, they talked about a little bit of clot on the edge, but, it was like, a 2.5, 3 centimeter mass, and it was myxoma. So I just always envisioned them as very slow growing tumors. And this one just dramatically increased in size over what is a relatively short period of time.
Yeah, interesting.
Yeah, I just haven't seen that before. This is something I never even heard about. And then someone showed me the case. I'm like, well, it looks like something. And then we Googled it. And sure enough, there are case reports about this. This is an old PET. And I'm just showing that the patient has a history of breast cancer. There's a little bit of thymic tissue in the anterior mediastinum, and some of it is, not surprisingly, has some uptake on FDG. Here is the patient then underwent a CT many years later. I'm not sure if it was a cancer follow-up. I'm not sure because there really wasn't anything in between. Oh, the wrong patient. That's the next case. Sorry. That's an interesting case. So here's the CT. And so she had breast cancer, and you can see there's more pronounced thymic hyperplasia, whatever. But what's interesting is you can see all of these areas of cystic change within the areas of thymic hyperplasia. And the more you scroll through, and if you scroll through very slowly, you'll see there's multiple areas of kind of cystic change within the thymic tissue. And someone raised the concern, I don't know, I'm not sure what they raised a concern about, but it led to an MRI. And I'm a little embarrassed to show you the quality of our MRIs, but you can see that, I'll show you the diffusion weighted imaging, because most of the images are not very good. You would think they would cardiac gate some of these, of course, but they don't. But anyways, all these areas of that were low attenuation on the CT, if you put them side by side, directly correspond to these areas of high signal on the DWI that do show T2 shine through on the ADC map. And I'd be almost embarrassed to show you our ADC map, but here we go. But they do correspond. So this is an entity, and anyways, so I started Googling this of like cystic thymic hyperplasia, and sure enough, I found this case report about cystic thymic hyperplasia in a patient with Sjogren's. And then I just happened to look, and these cysts are a little larger, but then I happened to look up her history, and sure enough, she has a history of Sjogren's. And it's something, I just hadn't heard before, but I don't know what the association with Sjogren's is on. She's repeatedly on bouts of steroids for her. She really has mixed connective tissue disease. She has a whole bunch of antibodies positive and displays multiple symptoms. But anyways, that was a new one for me. And they were wanting to take it out, but we were trying to convince them just to leave it alone. So hopefully they'll do that.
No, I've not heard of that association with Sjogren's. That's interesting. Oh,
Yeah, I hadn't.
interesting.
It's just I put in, I'm like, God, it looks like thymic hyperplasia and cystic. So I just put in cystic thymic hyperplasia. And then the first hit was this case report of someone with Sjogren's. And then I found a couple other case reports, along with case reports of people not with Sjogren's. And then I just, found her history, and sure enough, she had Sjogren's. And then this is the last case, which is just I think we've all seen this, but a nice example of a guy with pretty impressive lymphadenopathy, but high attenuation. Those nodes are pretty high attenuation. And some marked, going to progressive massive fibrosis, or in the progressive massive fibrosis in the right upper lobe, and extensive nodularity. Some of it's more random. There is clearly a perilymphatic component, but some of these are outside that distribution. And he is very young. I think he's 40. And he is a gentleman who works on fabrication of granite and marble and quartz countertops. And this is his
stone. Yes.
Yeah. So here is his path. So they did a biopsy, even though we're like, yeah, this is silicosis. So they did a biopsy, and you can see that here's all the polarized material, because they were wondering, obviously sarcoid's in the differential, but we had the history, or like that's, and then here's a beautiful silicotic nodule.
Oh, wow.
So, and this is from a cryo. So this is one of the nicer cryos where you get a nice silicotic nodule. So, so this is I think this may be the first young guy fabricating stone disease I think I've seen. I know people seen them. We know, papers on them, and I've seen plenty of people with silicosis. I just don't think I've seen a 38 or 40-year-old with this extent of disease.
Yeah. So Seth, I showed some cases a couple of years ago, and they were
Yes.
28 and 30-year-olds.
Oh, really? Wow.
And we had a film record on this person. You could see this stuff progress over a year. It was just amazing. It was explosive.
Yeah.
Yeah,
No, that's
under the accelerated silicosis clinical syndrome, because David, isn't it like over 95% silica in this manufactured stone?
Yeah, the stuff that they call quartz, which is very popular for countertops, it's 95% silica and a little bit of resin. So it's very, very potent. And these people are sawing this stuff and sanding it without protection.
That's crazy. Yeah.
And it's really tragic.
Yeah.
It's tragic.
Anyways, those are my cases.
Excellent. All righty. Who's our next presenter?
I think I have some, Jeff, here. If I can, maybe I have some here. I think I do.
We'll see if your computer cooperates this time.
Okay. Hang on one second here. Let's. Okay, I'm ready.
All right. It should ask you to pop up.
Here we go.
I'll take control back and then give it to you. Try this again. Just a little pop up.
Okay, so I think we're ready. Can you guys see something?
Yes.
Say
Okay,
right.
chest radiograph on this person who has been receiving chemotherapy for colon cancer, and he has this radiograph which looks kind of busy, but you know, it's an ICU radiograph, and so you don't know how much of this could be something acute like edema. But if you look at his lungs, he's got a ton of upper lung nodules, small nodules, and a very nice kind of sarcoid distribution, peribronchovascular, and along the fissures there, lots of nodules along fissures here. And in terms of lymphadenopathy, not much, but this was biopsied and this was sarcoid. So this was, he had a previous CT a couple of years before and there was nothing like this in there. So this was attributed to a sarcoid-like reaction to his chemotherapy agents for his colon cancer. So I was going to look up those agents and see which one. It was one of these cocktails he was getting adjuvant therapy to assist resection of a sigmoid lesion. So this is a sarcoid-like reaction here. Lots of tiny little lung nodules.
Yeah.
Okay.
Interesting.
Very good.
And let's see, I have to sort out which cases are which here. Sorry for the naivete here. Okay, that may be the same guy. Okay, this person has a pretty normal looking chest radiograph here, this outside radiograph. And I'll flip this around to conventional orientation, because I find I really can't interpret them very well when they're not facing the right way. And you don't see any hint here of the mediastinal lesion, which is quite large and very vascular here. So what do you think? Very vascular lung lesion. Before they resected this lesion, they did a lot of embolization procedures. IR did that.
Looks
So,
like a
Paraganglioma.
paraganglioma or
okay,
vascular malformation.
okay, it is
Or
indeed a paraganglioma.
Yes.
And this thing lit up nicely on a scan, a DOTA scan, but I don't have those. I can't show you that because it's not anonymized. So
can you show this on the a sagittal recon? Because I'm always wondering, you know, they're labeled when they're in this location as, I have to talk to a pathologist and determine if these are intrapericardial or actually mediastinal, because so there is pericardium going around it there, it looks like.
yeah,
Because some people list this as the cardiac, one of the cardiac paragangliomas in this classic location, and other people label it mediastinal. I never know.
that's a good point. So
Because
let's
that looks intrapericardial there, because the ones that are intrapericardial sit right on top of the left atrium like this.
yeah,
Yep.
well, indeed, I think, yeah, this would have to be intrapericardial.
Yeah, there you go. Yeah, no, that's clearly, yeah, there it is. Yeah. So some people
Okay.
list this as like a cardiac, you know, cardiac
Yeah.
paraganglioma, whatever. Semantics.
Got it. So the New England Journal this week had a you know, their case of the week was one of these paragangliomas, and I think the guy presented basically with heart failure, probably because of the endocrine output of this thing. Okay, and let's see what else I have. This is kind of a mystery to me. So this person had fever and cough, and has this dense, compact pneumonia in the right upper lung, and then with time the margins began to fuzz here and is probably spreading into the tissue around it, but it presented as a fairly compact and round lesion like this on this outside imaging here. So we always think with something compact like this that it's worrisome for fungus, and when it's this big and grows fairly fast, you worry particularly about mucor. So if this were a diabetic person, you'd certainly worry about mucor of some immune compromised person besides diabetes, like chemotherapy or something. And here's what it looks like on CT. This is late, and there's a lot of surrounding ground glass around the dense central nodule. I have some other scans. This actually shows up, I think, better on this view. So it's a very dense pneumonia. It does have vessels going all the way through it, so it seems to be well perfused. You know, typically with fungal lesions, like the invasive fungi, Aspergillus and Mucor, you interrupt the blood supply and you don't really get vessels going all the way through, because I think there's actually, you know, it's the angioinvasion that causes the big infarction component of these things. So the vessels are often blocked. So this turns out to be Legionella. And with a compact round pneumonia, you think particularly about Legionella McDadii. However, I've seen, this is my second case of Legionella pneumophila, which this speciated out as, where you also get that compact round fungal-like pneumonia. So Legionella pneumophila can do it as well as McDadii, but McDadii is the first Legionella consideration for a dense compact pneumonia that looks fungal but grows faster than even Mucor grows. Okay.
David, does Legionella produce a lot of pus like Klebsiella? Is that why it's kind of compact like that?
I don't know. Good question. I will try to ask my infectious disease people and let you know about that.
Okay.
My notion is that it doesn't. My notion is that it doesn't, and therefore people are worried most of all that they're seeing a viral pneumonia. When it's diffuse and it's sort of atypical thing and it's spread all over the place, ground glassy mostly, not dense and compact like this, then I think people are thinking that it's a virus, and viruses tend not to be that productive, at least early on in cough. But let me check with our ID people.
Okay.
So pneumophila is the usual agent, David, of Legionnaire's disease, right? Do I get that part right? I'm trying to remember.
That's right. Yeah, that's the thing that was first described, and it's what's usually there in the community-acquired stuff.
So someone should ask him what water he's been nearby, because usually people get that from contaminated water.
Right.
And you wonder what this person's occupation is. There was a famous history of a person that was diagnosed with that entity, and he worked for a flower delivery company, and he delivered flowers to the hospital frequently. And he walked through the lobby a lot, and they cultured the water in a lobby fountain display, and the water in the fountain was full of pneumophila, and that's where he got it.
Wow.
Recorded in the lobby water feature.
Yeah.
In the hospital.
We've had some hospital outbreaks here of Legionella, and they've closed wards and they've decontaminated things. And so we have this every summer we have this alert about Legionella, and they will get it out of the showers and the sink faucets in the patient's rooms. So this is why for 2023 I've given up taking showers.
In the hospital.
In general. Okay, I would like to show you this case of a woman who has a diagnosis of cardiac amyloidosis. She has a plasma cell abnormality that they detected in her bone marrow. She had a cardiac biopsy that showed amyloid, and she has a little bit of cardiomegaly here. At this point, she has a port catheter in place. And she has had a number of CT scans, many of which early on showed florid septal lung edema, and that edema finally resolved. And then it turns out that behind all of that, there was also this diffuse fine nodular lung abnormality. So we have a ton of small nodules, mostly peripheral, and somewhat more, I think, in the bases than in the upper lungs, but they're really involving all lobes. And some of these lesions have a hollow center, so there's some Cheerios involved here in terms of breakfast cereal. And for instance, here's a nice Cheerio down here. Here's a Cheerio over here. So Sudhakar happened to be in the room yesterday when this case came up, and he said there are very few causes of Cheerios. You think of Langerhans cell histiocytosis, some adenocarcinomas. I don't know whether he said pneumocyte hyperplasia or not, which came up earlier in the conference today, but he says the big thing is the meningothelial-like nodules. And so he thinks that that's what this is. So I looked up the description of nodules that occur with amyloidosis, and nobody has nodules of this profusion and this small size. Usually the lung nodules we see with amyloid are big and sort of irregular blobs. And there is often, accompanying cystic or emphysematous lung disease, as Howard has documented. So chances are this person has two diseases here. In addition to the cardiac amyloid and the plasma cell dyscrasia, there are these meningothelial-like nodules. I don't really think that these nodules are likely to be amyloid. What do you guys think?
I agree.
Yep.
I only
it's
see
pretty-
female patients, and they tend to be lower lobe predominant, and they're those
Right.
the kind of small shriveled up Cheerios that have been left around by a little toddler for a few days. A lot
These
of
are Cheerios recovered from between the seat cushions.
Right, exactly. They're the small Cheerios. But a lot of times, if you look at the smaller nodules, you can make out a subtle sort of umbilication.
Yep.
Yeah.
So
Okay.
Yeah. Very nice.
yeah, I agree.
Okay.
Agree with
Have you guys seen this profusion before, or is this kind of on the high end of number of nodules? What do you think?
I've
Yeah,
seen
it's
this.
on the high end a bit.
Yeah.
Yeah.
It's
Okay.
prominent, but I've seen ones with this many and ones with
Okay.
a lot less. Yeah.
And as far as I could tell, going back to 2020, when I looked through all the septal lines, these nodules haven't really gone anywhere.
Yeah, they don't
in
change.
that period of time, right?
Yeah, I
So,
want to see a case where we
Yeah.
see it like in a 50-year-old, and then we have a CT from like when they're, because usually it's these middle-aged women, and a lot of them have cancer, and that probably is just because we do so much cancer imaging here. But
Right.
like I'm wondering, do they have them when they're 20? Is it something that they develop? At what point they develop? How rapidly do they develop? Because once they're there, they don't change.
Yeah.
Right. And I know the pathologists see them not infrequently
All the
for
time.
biopsies, but not like to the degree of not meningotheliomatosis.
Yeah, no,
Right.
it's kind of like DPO, right? With they see with fibrosis, they see it all the time, and we see it now more frequently, better spatial resolution, but
Right.
not like they see it in almost every case if they look.
Got it. Okay. Seth, where are you these days? Are you still in San Diego, or have you moved?
Yeah, no, I got another week left here, and then taking a little time off, and then starting in Colorado at the end of February.
Congratulations.
Yep.
Thank
Good.
you.
All the best.
Okay, those are my cases, guys.
All right. Thanks. All right, Howard.
Okay. I'll show some as well. So let me start with this one. As you'll see in a moment, one of my favorite topics. So I was sitting in the reading room when a pulmonary colleague was discussing a case with one of my colleagues and mentioned cystic disease. So I'll give you a feel for these. Mostly small, some slightly bigger, but of this size, clearly involving the lungs diffusely. And there was one here where, for example, it's possible that there is a vessel that at least traverses, perhaps in part, the periphery of the cystic space. So the cystic space is developed in close proximity to vessels, but otherwise hasn't really disturbed them. There's a little bit of tissue there and a vessel passing through its periphery, but most, of course, are very small. So, I've shown a lot of these in the context of a whole variety of lymphoproliferative disorders, protein deposition in the lung. So the ones I've shown before include multiple myeloma, Waldenstrom's. I've seen it in pretty much everything. And this is my first time I've seen it in the context of MGUS, but in particular, as you'll see here, light chain MGUS. Now, light chain MGUS is, like all the MGUSs, often is an incidental finding when patients are worked up for different problems, and it's an incidental finding, but they're not really symptomatic from MGUS. And as you can see here, let me just bring that up. that with respect to MGUS, there's sort of three clinical types. So we have the non-IgM MGUS, and then we have the other one. If I can just get this to advance properly, let's see. I don't know what I did there. Okay, there we go. So we have IgM MGUS, then we have one variant, which is actually relatively uncommon, which is light chain MGUS. So that's a known thing. And sometimes they progress over time, as you can see there. So this is a really nice case of cystic lung disease associated with light chain MGUS.
You said there was a third type?
Where did I catch the third type? I think I missed that. So we have non-IgM MGUS.
Oh, non-IgM, or okay. And then was there IgM?
Then
MGUS?
there's
There you
IgM MGUS,
Got it.
the least
Okay.
common light chain MGUS. And some of these patients will be followed. They won't be treated, but they will be followed because some may progress to like light chain smoldering multiple myeloma, light chain myeloma, AL amyloidosis, and light chain deposition disease. Typically, we think of light chain deposition disease if we have the lung disease, but patients also have kidney disease as well. But you can get so-called light chain deposition disease confined to the lung, presenting as cystic spaces. But certainly, when patients are first diagnosed with that, they will evaluate them for the possibility of kidney disease and so on. So light chain MGUS for this patient, for the cystic disease. Let me show you a case. Now, I've shown these before, but I want to show one again, particularly if they're trainees watching this, because there are findings here that can easily be misinterpreted as occurred in this person. She was given the label of hemidiaphragm paralysis. So let me just get my timing right. This goes back to January of 2022, and you can see which part of the diaphragm is elevated back then. And I'm trying to think if I had a more recent CT to look at, but let me just try to remind myself about this case. But there was another CT, and there was also, and I thought I kept it, there was an MRI examination that I could look at that was involving the lumbar spine. And I could use that to show that, as you see here, that there is no atrophy of the posterior right hemidiaphragm muscle or the crus. And that was also the case on a previous CT and MRI. So typically, whenever I have these studies to do fluoro, before I go back to do the fluoro, I review the imaging study so I can kind of anticipate what I might see. So I could tell that there's no atrophy of right hemidiaphragm crus and no atrophy of the anterior muscle either. So let me show you the SAG, and I'll keep that up to show you the same kind of findings. So we can see here the point where we no longer see the right hemidiaphragm muscle. So anterior, we see it gets a little bit thin, and then we can infer or intuit that the muscle is going to get thin or would kind of disappear right here before it comes back again posteriorly and towards the crus. So this is the portion of the right hemidiaphragm where there is really probably just a thin membranous type of structure rather than muscle. So now I will show you the corresponding images. Let me, in the interest of time, bring up the deep breath. So this is nice because what I really want to emphasize here, as I've mentioned before, and as David has said before, evaluate these patients in the lateral projection because you're going to evaluate this portion of the diaphragm separate from here, as it were. So here you can see, I'm going to just scroll through that, and then you'll see that when the patient breathes in, which is going to come up about now. A couple of things. The diaphragm is moving, and it's actually moving very nicely. Even this posterior portion is moving, but the portion that moves very nicely is this more anterior portion that's muscularized. And perhaps as the patient takes a really deep breath in, maybe this portion is kind of dragged downward by virtue of the muscle contracting more anteriorly. But look how nicely that lung inflates overall with one deep breath. And now I will show you the sniff. I bring it up over here. And I'm going to go right to the end. So typically when I tell the patient to sniff and I coach the patient how to do it, I will give the instruction to sniff at the end of expiration. So there might be a breath or two. And as the diaphragm comes up, and I know the patient is going to take the next breath in, that's when I give the patient the instruction to sniff, having demonstrated to them beforehand how I would like them to sniff. So here's going to be the sniff right about here, right there. And this is going to really nicely show that with the sniff, this portion that's muscularized contracts, it moves down. This portion back here is going to move paradoxically, not very much, just a little bit, like right there, right there. So the findings are not paralysis. This is eventration. And David, I know you'll like this because you are the one that taught us to evaluate the diaphragm this way and to look for the paradoxical elevation involving just a portion of the diaphragm, whereas the anterior portion moves down with the sniff, just like that, right?
Cool.
You like that?
Yeah, indeed.
Yeah.
The unusual thing about this is that the eventration is posterior on the right. It's usually anterior. So,
yeah,
you know.
Yeah. I'll just, yeah. So really, really important to try to anticipate what you're going to see, fluoro in the lateral projection.
So,
You have it,
Howard, could you show us that coronal view that's just a few frames above?
yes.
Not the on the CT.
Oh, sorry.
So you, by the way, before Howard leaves the fluoro part, you can see that if you just saw the dome of the diaphragm on frontal view, which is what you see, you would miss the fact that part of that heavy diaphragm is moving normally. So you really have to do the lateral to distinguish eventration from, paralysis. So if you go anterior, please, on the CT. Okay, so one of the things about eventration is that as you get medially and start to go underneath the heart, eventration will return to normal height, whereas paralysis will let the diaphragm really be elevated all the way across to the left side. But if you have eventration, you'll see this peak, but you'll see a return to normal height medially, where, just below the right atrium and cava there. And that's because, as Howard pointed out, the posterior muscle is intact. There's kind of a band of muscle that goes from the anterior chest wall, sort of skims by the inferior vena cava, and then turns into that posterior muscle that Howard was showing us along the spine and goes down to become the crus. There's kind of a band there. So if that band is intact because you've got good muscle tone in it, it's going to pull the diaphragm down when you get near the inferior vena cava. So the shape of the elevation of the right hemidiaphragm, just on a frontal chest radiograph, often tells you that it's eventration and not paralysis, because you have this return to normal height by the time you get near the inferior vena cava, because that posterior muscle is intact. With paralysis, it's flaccid and it's not doing anything. It's not pulling the diaphragm down to normal height there. Cool. Thank you.
Yeah. Excellent. Let me see what I want to show you. This one is also really good for trainees. So in a trauma patient, and I'm sure you've all experienced this, when you ask trainees to evaluate a patient for pneumothorax, when the patient is recumbent like this, they will typically look right here. and they will talk about a deep sulcus sign, which is fine because we do see that. But if you only think about that and you don't have a nice deep sulcus sign, you might not perceive other relatively subtle findings of pneumothorax in the basal chest. So the other two things that are present here, the first is that in addition to the slightly deep sulcus here, the interface between the left hemidiaphragm and adjacent lung or air is very sharp. And if it's very, very sharp, you should think that it may be contacting air. And then the other place to look is right here. So it is very, very unusual. I mean, normally one doesn't see this. If you see this portion of the hemidiaphragm as a very sharp interface between it and air, unlike what we usually see, which is here, then you should again think of this portion of the diaphragm contacting pleural space air. So I don't think that's been given a name, but the corresponding location of the air, sorry about that, that got all messed up. So let me just try and fix that for you. I don't know why this does this. Go default. And the location of this air is actually here. So it's relatively posterior. So in the posterior chest, anterior, we see that, then we start to see that air. And I don't know if this is a real anatomic name, but just for descriptive purposes, I sometimes use the word phreno-aortic recess, as if the air has created a little recess there. It's just purely description. But that's the anatomy of the air that we see. It's in this location, it's para-aortic, and you can see nicely its contact with hemidiaphragm, making that very sharp interface. So just another place beyond this lateral costophrenic sulcus, deep sulcus, to look for air as well. And if you see that, confirmatory evidence, if you need it, that there's air there as well. So David, you can give us a nice name for that at some point. I don't know what to call that sign, but you got the idea. I'm sure you've seen that many times.
I think it's the Howard sign.
You've seen that many times. Okay, let me see, what time is it? Okay, can I keep going? I think I'm the last person, Jeff, right?
Yeah, maybe want to do one more or something.
Yeah. So this is a complicated case. I'm going to show it in two parts. The first part is related to the fact that the patient was transferred here pretty ill with extensive pulmonary opacities. You can see that he has a mechanical valve in and a pacemaker. And he came in with findings attributed to lung edema. Now, he came here already with a diagnosis, so I'll show you that there were a bunch of images in which one can see, I'm going to show you more radiographs in a moment, but mostly for another reason. But one interesting finding on quite a few radiographs was that there was only one leaflet of this mechanical valve that was imaged as a discrete structure. And here you'll see why. So when they did the coronary cath, you can see here they're doing coronary angiography, but the operator clearly was, for a moment at least, focused on this valve. And you can see here that the valve appears, the leaflet appears, I should say, but only one. So there's only one moving leaflet. The other one is fixed in place because he has a substantial thrombosis of that mechanical valve. And let me see if I have the history here. I don't think I do. Well, I do. Apparently, some years he stopped taking his anticoagulants over here. So thrombosed that valve, and you can see very easily that they were able to demonstrate that on TEE here as well, in the context of replacing that valve. So some nice imaging features of thrombosis of a mechanical valve and entrapping in particular one of the leaflets. Now he's had a stormy post-op course and has been here for quite a while. And I'm going to show you a couple of images. I will tell you, because there's tons of images here, that he's had repeated pneumothoraces post-op on the right side that in reading daily radiographs seem to be quite hard to manage successfully. So I'm going to show you that, and I'm going to just go forward in time to show you that he had conventional chest tubes post-op, fine. And then you can see here that he has a pneumothorax over here, and eventually, bear with me, he got a pleural space catheter. And I will show you that in spite of a catheter, and in fact 2 catheters, that they still had trouble with that pneumothorax. And eventually he got a new catheter that looks like this with persistent pneumothorax. So he had one catheter that was higher up that was taken out. And just prior to the CT, I'm going to show you this catheter was placed. And here we go. So we look at the CT, and you'll see that evaluating the location of the catheter he has at the moment, you can see that it really just traverses the right middle lobe and ends up here. So it is pulmonary. And then the other observation was made was that this opacity containing a bit of air right there goes all the way from there to there, and that corresponds precisely to the track of the catheter that he had previously. So this unfortunate person has had the passage of 2 pleural space catheters into lung, once in the right upper lobe and more recently in the right middle lobe. So my understanding is that at surgery, at least on the left side, because he had a left chest tube previously, he had a lot of adhesions. So I think in spite of the fact that these catheters are relatively soft, maybe because of adhesions, sometimes they're hard to place. And even though they're soft, they can go into lung. And this person had 2 of them on 2 separate occasions going into lung. And this one was taken out eventually, and here it is, still there, but our people put in this one up here, and then this one, which is in the right middle lobe, was taken out. So have you guys seen these relatively soft catheters going into lung with any frequency or sporadically once in a while?
I saw one as a fellow, but it was a trocar mounted one rather than one placed like over a wire, like they usually do in IR. And I'd be interested to know if these were like these kits with these like really sharp trocars, because it just goes right into the lung parenchyma, especially if you have adhesions.
Yeah.
Rather than when you actually create a space.
Yes. Yeah, maybe during the insertion, if there are adhesions and it's a difficult placement, you can end up getting them going into lung. Yeah.
Because they should go into the pleural space rather smoothly, whereas if you're in the lung, you should be hitting some resistance. Because that one looks like it's looped around the pulmonary vein.
This one here is the
Yeah.
one that's in
Looked
the
kind of
middle lobe area. I'll show you the coronal of that one. So here is the current one coming in laterally, and it goes there, ends up fairly close there, and then you can see the track of the one that he had previously going through there.
When they place these pigtails, do they have a stiffening wire to straighten out the curve on the end, the curl?
I don't know. I need to ask somebody, and I do have a colleague that puts these in. I'll ask him the method they use and the technique that they use and how they might end up going into lung, even though they're relatively small things, like this one did.
They must have something like that that straightens it out, and then that turns it into a lethal weapon.
Yeah.
All righty.
All right.
Well, thanks, guys.
Thanks, everyone. Happy New Year.
Yes, Happy New
Happy
Year.
New Year.
Talk to you later.
Okay.
Bye.
Bye, everyone.